Thank you all for being here. I must say I'm a little excited that I was able to get everybody to wake up and show up for breakfast and then here to listen to me. It's a little harder in the United States, believe it or not. 7:30, nothing's happening. Excellent. So thanks for the introduction, Rob. So I'm just here to talk about what the ActiPatch is, just have a conversation about the technology, where it fits in chronic pain, but just a little bit of background on myself. As Rob mentioned, I'm a biomedical engineer by training, and my expertise is in the use of electrical and electromagnetic fields and how it affects bodily tissue. And recently, I've been doing some research on pain management, and that's where I fit in with the company. I am a full-time employee of Bioelectronics. The device, it's made by Bioelectronics, so we make the device. And I do have a financial interest, so with that said, I'll just get started. And so, just to give you a quick overview of the presentation of what we're going to do today, I'll just introduce chronic pain a little bit, talk about some conditions, how they have an underlying causes, and how it links to central sensitization, where existing therapies may be not providing the most efficacy possible. And then we'll have a conversation about the concept of electroceuticals, which is using electrical or any other modalities that can regulate nerve activity for therapeutic benefits. And then talk about where the ActiPatch comes in, the clinical efficacy a little bit, how it works, et cetera. And then we'll open it up for questions later. So so let's get started with that. So you're all very well aware of these statistics, but I just thought I'd bring them up anyway. So just introducing chronic pain as a degenerative disease, just some common quality of life conditions that I'm showing here. I mean, musculoskeletal pain is the most prevalent of all of these types of conditions, but I've also linked some other ones here, as you can see, overactive bladder, linked to some bladder pain, and migraine and neuropathy. Now, these seemingly unrelated chronic pain conditions do have some underlying links here. As you can see, there are allodynia and hyperalgesia symptoms in some people, exaggerated pain, and they always do not have a definitive pathology. As you know, especially with something like knee osteoarthritis, radiological imaging often does not correlate well with the amount of pain reported by a patient. And there is limited efficacy from OTC therapies, which is what I'm here to talk about because ActiPatch is an OTC device. And so just want to talk about what OTC treatment strategies there currently are on the market. And the most common strategies employed are mainly to mask the pain or to reduce inflammation, or with alternative therapies like massage. Now with masking, technologies like TENS, creams, lotions or any ointments, and heat and capsaicin patches, thermal patches, these all just attempt to provide temporary distraction from the pain at the site. So the analogy being, if you bump your hand against a wall and you rub it, you feel good for as long as you're doing it. With NSAIDs and acetaminophen drugs, they do provide significant pain relief when there's inflammation at the source. But as we know, a lot of times with chronic pain, after the injury has healed specifically, there's not a lot of inflammation at site. And so inflammation does not always correlate with the amount of pain. As for alternative therapies, massage and exercise, there are benefits to those, but they also have found to be of limited effectiveness, mainly because it's hard for people with chronic pain to get them moving again, as you're all very well aware of that. And so just let's have a conversation about what normal pain signaling is and what chronic pain signaling looks like. And if you can see here, the images on the top and bottom, I'm just showing what the pathway of normal pain perception is and what touch perception is. So afferent stimulation, whether it be a noxious stimuli and non-noxious stimuli, mainly activate these two types of fibers. One is noxious fibers, which is perceived as pain, and the second is mechanoreceptors, which is perceived as touch. Now in normal individuals, this is how we differentiate between these two types of inputs. However, with the presence of injury or with constant activation, let's say in the case of knee osteoarthritis where there's actual damage, this constant activation of the afferents can oversensitize or overload the system here. And this can sensitize the afferent nervous system as well as the central nervous system. And when it happens at the central level, we call it central sensitization. I mean, the analogy I like to use is a peanut allergy typically. In the beginning, we get to take a lot of it, and over time, even tiny activation of these afferents can lead to exaggerated responses. And so what we see here, and how I would like to present chronic pain to you as, this is where perhaps it's time to look at it as a syndrome of central sensitization instead of trying to look at the pathology behind it. Central sensitization actually presents many similarities with memory. So nerve cells actually learn pain when there's central sensitization. So the pain can actually persist long after the injury has healed. Again, the example I like to use is knee osteoarthritis. And what essentially happens is there's a disruption in the habituation and sensitization processes. The example is here, let's say we're all wearing coats or we're all dressed formally, and after a couple of minutes, couple of hours, let's say, you forget that you're wearing your coat. What if you constantly keep jerking on your coat or your clothes? Your system never quite adapts to it, and so it's constantly being sensitive to these background levels of noise. And with hyperalgesia, there's exaggerated pain. But I'd also like to introduce you to the concept of something called afferent noise. But before we get there, let's look at the graph on the bottom left. The x-axis is just an example of stimulation intensity, and the y-axis is pain reported by an individual, let's say. So if you look at the blue curve, that is what would happen in an individual without chronic pain. As you can see, as you increase the stimulation intensity, the normal pain response peaks after a certain level of introducing pain. However, following injury, the gray area is what we would call the transition from acute to chronic pain, and that is where the onset of central sensitization can happen. And now with the onset of central sensitization, as you can see with the bottom left part, that's the area of allodynia, where even in the absence of any stimulation, there's false pain. And with the application of low-intensity stimulus, you can see that there's hyperalgesia. So essentially, we've shifted the pain response landscape from acute to chronic pain, and central sensitization is linked to that transition. Now, as for the image on the right, the more we understand about chronic pain and central sensitization, this is just an example of afferent noise with respect to overactive bladder. But the idea is that there's a lot of noise and information being transmitted with the afferents, and just pain is just one of them. There's pain-related information, there's mechanical information, there's chemically mediated information, and obviously the other ones that you see here. The concept is that with central sensitization, if your system starts to see all these other types of afferent noises, it starts to overreact to them and perceive them as painful stimuli. And so that's what the issue with central sensitization is. And so just a little overview on what prescription analgesics do and what some alternative analgesias do is, broadly, there's opioid drug-based therapies and non-opioid pharmacological therapies, and then new pharmaceutical therapies. Now, opiate drugs do have its place in pain management, so I'm not out here to talk about whether they're good or bad, but mainly they do have some limited long-term analgesia, especially when we followed some patients over a 6-month period. There's always the risk of dependence, and obviously with regular use, there's a risk of leading to escalating doses, especially in the United States, where we're seeing more deaths from opioid-related deaths than just automobile accidents alone. So it's a huge issue. And then there's the problem of opioid-induced hyperalgesia and allodynia in itself, and of course the significant side effects that many of our subjects report, especially constipation and others. So even though they're getting pain relief, they have these other correlated side effects, which requires some more medication and then a risky path from there. There are, of course, non-opioid pharmacological therapies that are centrally acting that can actually target the underlying cause at the nervous system itself. However, they have also been found to be have limited efficacy for chronic pain, and they also have a significant amount of side effects. Now, there are new therapies in the market, especially like anti-nerve growth factor medications, but as you're aware, about in 2010, the FDA stalled them due to some serious side effects, but now they're back for testing. Bottom line is that new drug therapies are being developed. Pharmacological therapies do have their place, but there are huge costs to developing them and are probably years away from coming to the market. So which leaves us mainly with what alternative analgesia options do we have when trying to think about chronic pain, especially in regards to nerve hypersensitivity. There's massage, behavioral therapies, mindfulness practices, etc. However, the efficacy has been questionable. And it's expensive, requires a significant amount of time and commitment from healthcare resources perspective, and so it doesn't really allow the patient to treat the pain in between sessions and other related conditions. And so the strategy really with a lot of people in this pain space has been that providing new information is essential to reducing central sensitization. That can be through exercise, through behavioral therapy, but essentially providing new information to these hypersensitive afferents is key to reducing this. And as you very well know, anyone with chronic pain, exercising while is the most important thing. It can often be very difficult to get them to start exercising in the first place because of that pain. And so the strategy that I would like to talk about with respect to reducing chronic pain is reducing the hyperactivity of nerves. Instead of treating the pain itself, providing analgesia by reducing this hyperactivity of the nervous system. So just a little map of what we've discussed so far, but essentially constant activity, constant stimulation of the peripheral nerves from an injury or active lifestyle. When I mean active lifestyle, something like running with plantar fasciitis, for example. It can lead to the development of sensitivity to this afferent noise or just general activities, and lead to the development of central sensitization, where the key factors are hyperalgesia and allodynia. Now, if you look at chronic musculoskeletal pain or some of the conditions that we have here, restless leg syndrome, fibromyalgia, irritable bowel syndrome, and migraine headaches, these have all been linked to central sensitization and hyperactivity of the nervous system. So the key here becomes, if we treat the relevant peripheral pathway that is sensitized, or even at the central level, can we actually relieve pain in some of these conditions? And that's what we're here to talk about today. Now, I would like to introduce to you the concept of using electroceuticals for pain relief, especially to regulate nerve activity. Now, electroceuticals are broadly any therapies. They don't have to be medical devices. They can be chemical in nature, they can be mechanical in nature, they can be electrical in nature. But when you use a medical intervention that regulates the activity of nerves, especially via neuromodulation, that's called an electroceutical. Now, electroceuticals have been around for a long time, the first being pacemakers introduced in the 40s and 50s. So this is really nothing new. But as our understanding of it has progressed, the technologies, especially with regards to pain, can be classified in two categories here. One is invasive options, and the other is non-invasive options. With invasive options, there's acupuncture, and the most popular electroceutical out on the market is spinal cord stimulation. They do have their place, but obviously I'm here to talk about OTC strategies, and there are obvious risks and side effects of cutting patients open. The recovery from the surgery itself can be quite challenging. And so with regards to non-invasive options, on the market, there's mainly two types of technologies. One is the use of TENS, which is transcutaneously stimulating nerves for pain relief, or even it has been linked to treatment of depression, especially for vagus nerves, etc. And the other is using non-contact, non-invasive electromagnetic waves, which is diathermy. Now, the history of diathermy has about 100 years old, but it's essentially using very high frequency, high power waves to warm tissue and improve mobility and such. While TENS is extremely popular, it does have its limitations. And I say popular because of a survey that we did in the United Kingdom and about 5,000 subjects, more than 20% indicated that as part of their multi-model treatment strategy, they do use TENS. However, there are some limitations, such as each person requires a custom combination of these parameters to achieve optimal pain relief, and so that often requires multiple sessions before they find a combination that works for them. And the paresthesia produced by the device is often not desired by many individuals. And the most obvious limitation is that most TENS treatment sessions are limited to typically 20 minutes or less, and you can't use them for more than 1 or 2 sessions a day. The risk of it being that you can damage your skin. And TENS is also not possible to use over bandaged skin or any clothing, or especially the elderly with fragile skin. And so there's these limitations. Where the ActiPatch technology comes in as an electroceutical is it can provide all the benefits of TENS plus some more while overcoming the limitations. And so the essence of ActiPatch is that it's a wearable device, it is paresthesia-free, and it also achieves neuromodulation. The scientific name for this technology is pulsed shortwave therapy, and it does not result in any thermal effects. Just in the next slide, I will give you a quick overview of what the ActiPatch is, what the technological characteristics are, how the device looks, etc. But on the table in front of you, we actually do have a device along with the description and a pamphlet, and I will walk you through what this is. But if you look at the image on the top, that is what the signal from this device looks like. As you can see, there is a main carrier frequency that operates about 27 megahertz that is pulsed at 1,000 hertz. So we essentially have a high frequency signal being pulsed at 1,000 times a second. And the power level is typically about 73 microwatts per centimeter squared. Just to put it into perspective, it's about 200 to 300 times less than the average power of a typical mobile phone. So we're talking about power levels that are incapable of causing any deterministic nerve stimulation or warming of the tissue. Now, the advantages of this technology are, since it's not deterministically activating afferent nerves, it can be used 24/7. So we have not found that patients adapt to the stimulus or there's a need to remove the stimulation after a couple of hours. And perhaps the most likable feature of the ActiPatch, as reported by customers, is that it can be used over bandaging and clothing. And so we've found people using it in a range of conditions, which I will talk to you about soon. But the device has a depth of penetration about 5 or 6 centimeters in soft tissue, so it can be placed over multiple anatomical locations. Now, for the device itself, it's actually on the bottom right. It's actually a little electronic module, and it has a wire loop. The treatment area is actually not underneath the module, but within this wire. So it produces electromagnetic energy. So the goal would be to center your area of pain within this treatment loop and just leave it on there. So now that we've spoken about the ActiPatch as an electroceutical, where does it fit with regards to how does it actually provide pain relief? What is the mechanism of action? Well, we've found over the years that the ActiPatch works by regulating nerve activity, by a neuromodulation. And this is some work that I did in graduate school as a biomedical engineer. But what we used was the ActiPatch to regulate plantar nerves and saw that it activated, improved the activity of secondary heart, the soleus muscles in your leg. And so we were able to evoke motor responses by stimulating the plantar nerves. So that's how we got our mechanism of action of sorts. But the hypothesis here is that we are not masking pain, but in a sense, reducing the hypersensitivity, interestingly, by increasing the afferent noise. So if you remember, our hypothesis is that increases in afferent noise are being perceived as pain by the nervous system. So our strategy is to increase the background level of noise. As I said, it's paresthesia and sensation-free, such that your system is now tuned to this signal, and over time, you're teaching the nerves to unlearn the pain. Now, the objective here is to reduce pain by increasing the tolerance of our patients. And so in one of the studies that we did that I will discuss with you, we have quantified it by using some sensory tests. Essentially, we did some pain pressure threshold testing for knee osteoarthritis and found that individuals who actually used ActiPatch reported higher tolerances to pain. So that is early evidence for why we think it might be reducing nerve hypersensitivity. Obviously, a lot of work needs to be done. But the fact that people can use this 24/7 means that people can actually get pain relief at night, which is key when compared to technologies like TENS, because there's no paresthesia. And this has led expectedly to people being able to sleep better, function better, and overall have a better quality of life. Now, I just have a little video here just to show you how a post-electromagnetic field is actually detected.
The ActiPatch produces electromagnetic fields similar to those used by your cell phone, but at 1,000 times lower power levels. As you know, cell phones do not help you heal, nor do they treat your pain. So how does the ActiPatch work? The difference is that the electromagnetic fields produced by the ActiPatch are not continuous, but are turned on and off 1,000 times a second, producing short bursts of energy. This demonstration will help you understand the mechanism of action. The black box represents a part of your body where you have injury or pain, and the beads in this small box on top represent nerves within that body part. As the ActiPatch is brought close to the body, the electromagnetic fields it generates create electrical currents in the body. These currents then feed back to the ActiPatch to affect its output. The result is that the body experiences only the very small energy bursts. So, how do the nerves in the body respond to these very small energy bursts? The answer is through a phenomenon called stochastic resonance. The nerves can't respond to every burst, but just the occasional burst that arrives at the right time. Think of it like shaking a salt shaker. Gravity pulls salt out of a shaker when you turn it upside down, but a tiny bit of shaking dramatically increases how fast the salt comes out. The thousands of pulses each second produced by the ActiPatch serves to shake the nerves, increasing their activity. You can see this phenomenon in action when the ActiPatch is moved closer to the box. Beads start to respond, but only a few times a second. The nerves in the body are like these beads. They are either activated or not. They cannot be activated just a little bit.
Obviously, it's a simplification for purposes, but the idea is what we've essentially done there is use the ActiPatch as a trigger. So when we get questions is how do we know the signal's pulsing, that's how we like to demonstrate. And we actually have it in our booth downstairs. It actually makes quite an amount of noise. So for those of you who are interested, please walk over. But these are some examples of the anatomical placements of the ActiPatch that currently are on the market and that are brought to market by Evomed here. But our most common application is for back pain, followed by for knee pain. As you can see, the device itself is in a wire format, which means you can apply it in any comfortable fashion to the body. Shown here, for example, is a back wrap for the knee and the back. And as you can see with the tendonitis on the shoulder, we just use some adhesive or some kinesiology tape. Individuals with neck injuries, especially from whiplash, we find they just tape the device onto a scarf and then they just wear the scarf. So we are essentially in a situation where ActiPatch can be worn discreetly and the benefits of electroceuticals can be had without any bulky or any uncomfortable sensations. Now just a little bit of the clinical evidence and what we've done so far. We've done two main types. We have a couple of randomized control double-blinded studies that we've evaluated the ActiPatch with, and the ActiPatch is FDA cleared in the United States and has a CE mark in Europe, and it's also been cleared by the TGA in Australia. So we've been slowly increasing and improving the quality of our evidence. And then we also collected some registry data on a lot of patients in the United Kingdom, especially the 5,000. In the first slide, let's just talk about the musculoskeletal pain clinical studies that we've done, which is what we originally believed the ActiPatch was intended for. So in the knee osteoarthritis study, by the way, in all these studies, our average population size was about 60 to 70 individuals, and so about 30 in each group, placebo-controlled. So we found that ActiPatch not only reduces pain, but it was able to demonstrate improvements in disability indices like the WOMAC index or the Oswestry Disability Index. But most importantly, we found in the knee osteoarthritis study, for example, that pain pressure threshold testing showed that individuals, both distally and right at the source, demonstrated significantly higher tolerances to pain than their counterparts. So that was very exciting for us. And with plantar fasciitis, the idea was to treat the plantar nerves, or specifically the branches of the tibial nerve. So that's where we treated it. And we found that the morning AM score, which was the measure for plantar fasciitis, we found that it was significantly better when compared to the placebo group. And most exciting for us actually is the back pain study, which we have submitted for regulatory review, so I can't share the actual numbers with you, but I was able to just pull a couple of graphs for you. The summary of that is this is for chronic non-specific low back pain. It was a 4-week study for 70 subjects randomly assigned to receive a placebo device or an active device. The placebo device looks exactly the same, the advantage being that both of them produce no paresthesia, no sensations whatsoever, so the subject is actually truly blinded as well as the physician. The results in summary are on the graph on the bottom right. The y-axis is just, basically this is a probability distribution function. What we were able to do was combine a lot of metrics like VAS, disability index, sleep quality, medication use, and just aggregate it, which is why you see 173 measures. So it was about 6 measures per individual, so that's why we had the 173. And then we normalized it to an index. The distribution in gray and black is the distribution for the placebo group, and the distribution in red is what you see for the active group. As you can see, the placebo group mostly stayed the same or got slightly worse when compared to the active group. And we found that this distribution was significant with a p-value of less than 0.001. So that said, we also went out to the UK and collected some registry data on about 5,000 individuals, and we managed to publish 2 studies. And this is where we saw people using it for indications other than musculoskeletal pain. But the summary of these findings from the 5,000 patient registry is that about 2 in 3 users reported that their pain was halved in about 7 days. Now, I must admit that there would be a placebo component to it, but we can leave that for the question and answer sessions. But there's more than 70% of individuals reported being able to sleep better, and this led to a cascade of effects of increased physical activity. And most exciting for us is about 65% of people cut their analgesic use, especially opioids, and we saw a corresponding decrease in side effects associated with the opioids as well. And so we were excited to see that in the real world, people were using ActiPatch for a variety of uses. As you can see on the right-hand side, while we've indicated it for musculoskeletal pain, we found that people use it for post-surgical pain, fibromyalgia, and neuropathy. And that's when we started investigating because we weren't sure why it was working for these conditions. And that's when we realized it was actually the neuromodulation component, and it could be reducing the hypersensitivity of nerves. Now, we've also done some non-sensory testing, like non-quantitative testings, to see if we are able to reduce some hypersensitivity and central sensitization. And so we conducted a self-reported registry study on about 174 individuals, and we just did baseline versus 7-day treatments. And the central sensitization inventory is what we use. It's a 25-question, 2-part questionnaire reported by the subjects that documents how likely they are to present with a clinical diagnosis of central sensitization. And Part B, as the acronym stands for, DCSS, is Diagnosed Central Sensitization Syndromes. And these were the syndromes that people reported, ranging from restless legs to anxiety to irritable bowel and the entire spectrum there. Now, if you look at the graphs on the right, on the top right, what we have is on the x-axis, we plotted individuals who have reported pain for a particular duration, for example, 0 to 6 months. And there's individuals who've had pain for 20 years or longer. And on the y-axis is their CSI score. The CSI score goes from 0 to 100. And the clinical diagnosis is if your score is greater than 40, then you are likely to be diagnosed with central sensitization clinically. And so what we did was we plotted baseline VAS measures and the CSI scores on the same scale. And as you can see, there appears to be a trend that they're correlated. And this is exciting because while we were not able to collect and see if CSI scores decreased after 7 days, because it would be foolish to think that we can reduce hypersensitivity in a matter of days. So what we did anyway, as you can see in the graph on the bottom, is we took measures of VAS pain after 7 days. And as expected, the ActiPatch does reduce pain in just about 7 days, which is why we have a 7-day trial. We will talk about that in a moment. But this is exciting because it provides early evidence that maybe in future studies where we can use 4 weeks or 8 weeks or 12-week studies, that there is some chance that we can also reduce central sensitization and document it via subject-reported questionnaires, or also with pain pressure threshold testing and other quantitative methods. And just a little bit of contraindications. That's one of the key features of this device, is mostly a lack of those conditions, but there's 2 main aspects that can lead to contraindications. One is from the ActiPatch signal itself. It is paresthesia-free, but in about 1 in 500 or about close to 1,000 individuals, we have a temporary increase in allodynia, like some temporary pain. And when we ask the individuals to remove the device, it does go away in a matter of an hour or so. But as a researcher, this to me is indicative that it actually is performing its pain relief duties through neuromodulation. So we are continuing to document and see if there's an increase in these conditions, but discontinuing device use alleviates the condition. And the second is from physical contact with the skin. I mean, the fact that it's a wearable and that you have it on 24/7 means that some individuals do not like the physical aspect of it, like the wire can rub on your skin, chafing it, or some people have some contact dermatitis. But it's easily avoided by just cleaning the skin regularly, or just even better, using it over clothing, which provides some distinct advantages. And so what we recommend is just taping the area, or maybe using a sleeve of some sort, if it's the knee, for example, and then taping the device over the clothing. That easily takes care of these conditions. And just now a quick slide on how to use the ActiPatch. It's actually very simple. We've designed it for over-the-counter use. As I said, everyone at the table has a device sitting in front of you in a 7-day trial envelope. And the idea is that people are usually skeptical, especially, I was skeptical as a graduate student as well. And then over the years I've found that it does have some effects. But the 7-day trial, as the name indicates, lasts for about 7 to 10 days. And once you turn the device on, it cannot be turned off. But the patient usually knows within this trial period if the device works for them. I mean, we are mindful of the fact that not all therapies work for all individuals, and ActiPatch is part of a multi-model treatment. And so we find empirically from our 5,000-person study that most individuals report pain relief within 3 days. So if you use the ActiPatch effectively, if it works for you, you'll know in a matter of a couple of days if it works for you. So it's very simple. You turn the device over on the back, and if you hold that silver button and press it, it turns a green light on, and then it's ready to use. And as for application of the device, we do get some questions on where the treatment area is. It's not underneath that module. That's just the electronics and the battery. So the treatment area is actually within the loop, and we center it. And as for initial treatment, we recommend 24 hours a day in the trial period just to know if the therapy works for you or not. And after that, we find that most people are able to dial back their use. In the full version of the device, there's an on-off switch. So people can dial back their use, and we find that they can use it for 8 to 10 hours a day or overnight, and that seems to be working just fine. And just some future research that we are doing in some ongoing clinical trials is we're personally doing a study on migraine. The idea is to treat the upper branches of the trigeminal nerve, or maybe try to place it over the trigeminal-vascular pathway, because migraine is also linked to hypersensitivity of the nervous system. And we have an ongoing study in Indiana. And the second is the use of a smaller device. Now, the key with this technology is the ActiPatch is just a vehicle for applying this electromagnetic energy. There's a number of things we can change, like power level, how fast the signal pulses, how big the treatment area is. And so what we've been working towards is optimizing a combination of these signals for specific nerve bundles in the body. And so the ActiPatch, that in its existing form, we're using it for anatomical placement over the knee, the back, and the shoulder. But in this future products like overactive bladder, recovery from chronic wounds, and other things, we are using a smaller device because the average area of a chronic wound is about 40 square centimeters. So we have that research going. And we also have about a 70-person study going on in the UK to investigate the effects of this technology on primary dysmenorrhea, which is also linked to hypersensitivity of the nervous system. So there's a lot of work going on for both painful and non-painful conditions, and that's the pathway that we are taking. And just an overview of what we've spoken about so far today is just, if we think of chronic pain as a degenerative disease linked to hypersensitivity of the nervous system, then OTC therapies in its existing form offer limited effectiveness because they're not treating the underlying condition, that is the nervous system issues. And so if we look at ActiPatch, what it does is provide the benefits of an electroceutical technology in an economical format. In the 7-day trial that you have in your hand retails for about $15 in Australia, and gets people a chance to try it. And the 720-hour version, which is the long version, retails for about $59 and lasts anywhere from about 6 weeks to about 12 weeks, depending on the patient's use. And we do find that the fact that there's no paresthesia means that individuals can use it for 24 hours or even as an adjunct in between treatment sessions, et cetera. And we have found that it does have some good clinical evidence. We are continuing to strengthen it, and we're also improving our research for other syndromes of central sensitization. Yeah, but with that said, I'll be happy to take any questions and any more that you have to ask about the ActiPatch. Yes. Yes, we do have a protocol listed on the NIH clinicaltrials.gov website, so we do have that available, yes. In fact, we have results coming in. We've had some encouraging results, and for those individuals that enjoyed the benefits but reported some problems, as you can see in this image, we fitted into a little sports headband, and we found that the compression from the headband sometimes is not very helpful. So we're moving towards placing it at like a band, or maybe even just taping it on. And so
Is it recruitment finished for that? You're not going to anymore?
I'm sorry?
You've finished that study, or there's not any ongoing recruitment?
It is open label at this point. I'm not open label, I'm sorry. It is still open at this point. We have reached our fulfillment numbers, but we are keeping it open just to document more, because it is a pilot study. So just to learn more about it, so.
So I have three things that I wanted to say, or
Please.
questions. So the first one was, what's the depth that the magnetic field can go? Because I'm just interested, are you treating the actual sensitized primary afferents that is driving ongoing central sensitization, or are you actually just getting some sort of afferent input to this central nervous system to try and reverse, I guess, that nociplasticity that's occurring? The second question was, because you're looking at this as being part of a multimodal treatment, have you looked at studies that have compared ActiPatch by itself versus ActiPatch with like more active treatments like exercises versus a placebo or controlled kind of study? And the third thing is, it makes me, I sort of shudder when I hear chronic pain being called a degenerative disease. Sorry, I just wanted to bring that up as well.
Thank you for your questions. I'll try to answer them in the order that you've asked. So let's go to the third one first. I'm sorry that I had to say that chronic pain is a degenerative disease, but this has mainly affected me with individuals that I've seen in my family because with my grandparents and such, just the quality of life that they suffer as due to chronic pain just leads me to think of chronic pain as a degenerative condition, especially with neurological diseases. As we live longer, we are more likely to experience these conditions. But I'm sorry if I offended anyone in this room with that label. But that said, with the first question being how deep the technology penetrates, so it really depends on the individual, but we find that in soft tissue and muscle, it can penetrate up to 5 or 6 centimeters before it loses its efficacy. So as to your question as, are we increasing the afferent noise or providing information to the nerve endings of the afferents itself? Our hypothesis is that we are increasing afferent noise. Given that this is a non-deterministic stimuli, there was no way to particularly measure nerve activity. We've tried, I'm blanking on the name, but essentially we've tried an invasive procedure where we can actually record the nerve activity using tungsten electrodes. But given that ActiPatch takes maybe a couple of hours or even a day to show its effects, it's very hard to conduct studies asking patients to sit still for a while. And so our early evidence has been, as I said, we stimulated plantar nerves and documented changes in activity of the soleus muscle. And so that's really been what we've been doing. As for the second question, have we done head-to-head comparisons with our other technologies? No, we have not. We have mainly done ActiPatch by itself with randomized placebo-controlled trials. However, some indications of head-to-head came from our registry study. This was self-reported data. We didn't even collect it. Oh, not that. I'm sorry, I must not have had it here. But this just gives you a snapshot, the table on the right. So it's usually self-reported and how it compares to other modalities, but we, in good faith, ask people not to go off their existing treatment regimen. But you're right, we have to do a head-to-head about how does it compare to exercises, how does it compare to TENS, other strategies, absolutely. Yes, sir.
I can imagine lots of patients wanting to wear multiple devices on, both knees, both shoulders, and so forth. Have you had any experience with that sort of situation?
Absolutely. It's a funny story because in the UK, when we first started documenting how many devices people buy on average, we saw it was 1.7, and then it took a while to figure out that people have 2 knees. But yes, it is possible for people to use multiple devices at a time. The only thing we ask is that they're not placed right next to each other. It's not because for risk of danger, but the fields can cancel out each other if placed improperly. So as long as they're separated by 2 or 3 centimeters, they can be placed, multiple devices can be placed. Does it help answer your question, sir? Awesome.
Could I go back to your slide that's got the Birmingham Women's Hospital?
Yes.
Oh, no, go one more, I think. Anyway, the question is, where is the electrode stimulation or the stimulation being applied for dysmenorrhea?
We are actually placing it right over the abdominal area. So we're trying to hit, to be honest, we're not really sure what we're hitting
Well,
at this
that's why
point.
I asked the question. If you think about where women in labour prefer to have their back rub massage stimulation. It's not over the abdomen.
Yes.
I would have thought maybe the low thoracic would be a better place to apply any neural stimulation that's meant to be opposing pain stimuli.
You do bring up a good point, sir, because with our overactive bladder indication, we find that it's actually sometimes working better placed on the back, depending on the individual, because of how it can penetrate the sacral plexus a little easily from the back as opposed to the front.
Well, Alexis as well.
I'm sorry, sir?
The bladder and uterus have got both lumbar and sacral.
I'm sorry, can you just give me...
You might need two devices, perhaps.
Perhaps, yes.
Two questions. One is, how long do you need to keep using the patches? Is it a maintenance thing? Is it a one-off for a month? And the other question is, in fibromyalgia, which tends to have total body pain, where do you start?
Both great questions. So the first question is, how long do you keep using the device? It really depends on the etiology of their pain. In conditions where there's a pathology, we find that people usually discontinue device use after a month or two, which I believe coincides with natural healing of the injury. However, in cases like knee osteoarthritis, where there actually is damage to the knees, we find that, for example, we can take their pain down from a VAS score of 7.5 to a 3.5 or 4. So they do have to keep using it to keep the pain at bay. So it really depends on the etiology of their condition. As to the second question of the fibromyalgia pain, we actually never even indicated it for fibromyalgia, but we found that patients respond better when they treat the most painful area first. And the idea is being that if you actually do reduce hypersensitivity, then we should see systemic relief of some sort. So we find that individuals place it on their most painful spot.
Are there any areas where it's not recommended to use? And also I notice on here that it says not recommended for pregnancy or children under 16 years. Can you comment on that a little bit further?
Yes, ma'am. Actually, you do bring up a good point. I'll also address the can you use it over implantables and implanted electrical devices. So the first thing, the reason we have to put that on there for pregnant women and children is specifically because we have not evaluated it. And it's one of those lightning rods that are best left untouched. So that's the reason we did not evaluate it for that purpose. But our understanding of the technology is that it should not have any side effects for placement over specific parts of the body. Now, we don't know, for example, Rob here has told me that he's had some headache and he just placed it on a cap and put it on his head and his headache got better. But I find that difficult to explain, so which is why I don't advocate placing it on the head directly. So placement where there's known neural pathways are often recommended. Does that answer your question, hopefully? And the other, so to talk about the implantables question, the power level is so low that it does not have the capacity to heat tissue, which means that it's safe to use over implantables. And with respect to pacemakers, pacemakers are built to shield out these kinds of frequencies. So while it would be best not to place it directly over the heart, we don't see the ActiPatch as being any risk to these technologies. Yes, ma'am.
You referred to the longer acting ActiPatch, the one that's not the trial version, that has a limited life as well. How long was that?
Yes, ma'am. So both devices are meant to be wearables. So the longer device is 720 hours of therapy. So if you use it overnight, that lasts you about up to 3 months.
Okay.
The reason, I'm sorry, go ahead.
Oh, sorry. I was just going to say, so that's for someone with a chronic condition, that's an ongoing cost of continuing to use the device and having to replace it.
Absolutely. And to your point, we did try to come up with a rechargeable or battery replaceable version. However, we're facing two challenges in that if you try to make it rechargeable, removable, it increases the size of the module of the device and our costs go up significantly, and it also makes it very uncomfortable to wear because it looks like a medallion and it kind of dangles against the skin. But as for improving affordability, we're working here with EvoMed to try and see if we can bring this to reimbursement, because as of April 1st, 2018, it is available on the drug tariff in the United Kingdom, so it is being paid for by the National Health Services. So our objective is to try to bring the price down as much as we can to make it affordable for patients. Any other questions, anyone? Yes, sir.
I've examined the size of the battery in it. It's not that big. Why can't it be replaced? We replace batteries in watches.
Yes.
And most of the guts of the watch are nothing to do with the battery, so it could be very small.
Absolutely, good question. And what we've found is, if you remember the case of contact dermatitis that I mentioned, yes, we found that having people, so this is not hermetically sealed, but it is fairly water resistant. First of all, it would lose that capacity. And our concern is that making it removable would lead to accumulation of sweat. And we have seen instances, especially with, I should not mention companies, but wearable watches, accumulation of sweat near the electrodes and the battery can lead to discharge of battery acid and damage of skin. And so we just haven't done enough research in that direction to make a solid, replaceable device. And for sanitary purposes as well, so. Yes.
So I was just curious, you mentioned that some of the trial participants who used the module had reduced their usage of medications.
Yes, ma'am, yes.
So I was wondering about what happened to them when they stopped using the module in terms of their medication use.
Excellent question. So what we've done was we answered this, we asked this question over a 6-month period to see, I mean, I have to accept the fact that with any pain intervention, there is bound to be a placebo response. And we do find in our clinical studies that we do see the standard 25 to 30% placebo response, and the difference being the efficacy. So we studied this technology over a 6-month period, and we find that the pain relief is usually maintained and that analgesic consumption is more or less tapered off. So I don't have exact numbers on that, but we do find that people who reduce their medication use continue to keep it low. And in some individuals, they have eliminated their medication. So, but we only have data over a 6-month period. Yes, sir.
I have 3 questions. One is I'm US, so you said it's FDA cleared. Is it available in US now clinically?
Yes, sir, it is available.
Is it reimbursable by insurance or self-pay?
No, it's available over the counter. So in the United States, we have it cleared for 2 conditions, which is the knee osteoarthritis and plantar fasciitis. And the back pain study that we've submitted is pending. But what that would bring us is systemic musculoskeletal pain clearance. But the rest of the world, we have approval to use for any soft tissue conditions.
So over-the-counter means self-pay, right?
Yes, sir.
Yeah.
Amazon, and I mean, right now we launched it on Amazon, but we're working with retail partners to bring it to pharmacies and brick-and-mortar stores.
And when you use for low back pain we frequently use a spinal cord stimulator. Can you use together with spinal cord stimulator? Or
In conjunction with spinal cord stimulators?
Yeah.
If you're asking if it will damage the spinal cord stimulator, no, it will not. But we have not specifically evaluated if it might help people who use spinal cord stimulators.
But if the batteries and the lead goes close to the
right.
this device, where it causes damage to the spinal cord.
No, the power levels are way too low, and all implantable medical devices are built to shield these frequencies out. So this is 27 megahertz. To 27 megahertz and 40 and 915 megahertz, they're shielded by implantable electronics, and these power levels don't penetrate.
Another question is, you have used in the migraine headache.
Yes.
There is an anecdotal report, prolonged use of cell phone could cause brain cancer. And this looks like a electrostimulation too. If down the road you have a widespread use among the migraine headache patient, do you have concern it may cause brain cancer or increase incidence of brain cancer?
That is a question that has challenged the field of electromagnetic medicine for about 50 years now. And it really depends on the power levels of these fields. I mean, the study that's linking it to brain cancer has provided some evidence, yes, but transcranial magnetic stimulation, for example, is already present in medicine. And we just find that the mechanism of action is through neuromodulation, so we have not found any in vitro evidence that it actually proliferates cancerous cell growth or anything else like that.
But I think the key is if there is, it will be very low incidence. So you, in an experimental clinical trial setting, you will not have enough subject. So it will only in like phase 4 when you use very widespread, because I can see if this is effective or helpful, it will be used widespread because it's not a medicine, it's a kind of a simple device, and it's likely to be affordable, not like surgical implanted. For surgical implanted, certainly you have very limited subjects, so you may not see the incidence if the incidence is very low.
I suppose the answer is we obviously have to do more research on placement over the head, which is why the only condition that we've seen so far is migraine, and obviously more work has to be done to see if there are any serious side effects. But it would be difficult to do a study long-term to see if there's any negative effects with stimulation over the head.
With stimulation over the head, my concern is more that we use transcranial nerve stimulation is being used in psychiatry for its effect on the central nervous system, on the brain, and your penetration is such that you would be changing things in the brain, if 5 or 6 centimetres. So have there been reports of psychiatric side effects with use over the head?
The only clinical study we've done, even on a pilot level, is with the migraine study, sir. And it was over a 4-week period. So from the data we have so far, we have not found any effects of psychiatric-related conditions. Although with the migraine condition, we're documenting multiple things. We're documenting medication use. We're documenting the frequency of migraines, the intensity of migraines. And so we have not found any evidence so far as to having side effects, especially psychiatric ones. But as I said, we do find that the compression of the headband is what can sometimes increase pain. But that's been about it. But to answer your question, with transcranial magnetic stimulation, power levels at that frequencies and those high power levels are known to deterministically stimulate neurons. But our power levels do not actually evoke action potentials. So the mechanism of understanding is fundamentally different, which is why we believe it is relatively safe to use.
Is there any interference of the activity if it is placed over any metallic device such as prosthesis or any plate in the vertebra?
No, sir, because the power level that is required to warm tissue is generally about 10 milliwatts per centimeter squared. This is about 100 microwatts per centimeter squared, so it's about 100 times lower than the energy required to warm tissue or metallic implants. So it is safe to use over prosthetics and such.
Just a quick practical question. Can
Yes,
you wear it in the shower or the bathtub?
Yes, believe it or not, we do get that question a lot. Now, the device is not hermetically sealed, so I wouldn't recommend going for a deep ocean dive. However, it does do pretty well with taking a shower. We just don't recommend taking a bath for a long time or going swimming because the pressure can actually cause some water to permeate through the barrier.
Hi, just looking at what you used as a placebo, whether it was the same sort of device put on the area or without the battery inside of it, just because there's been some evidence to show the more expensive the placebo is, the greater effect it has. So if people can differentiate between the placebo or the patch, then there's a potential that they understood. Obviously, there was a difference, so just interested in what you used as a placebo.
Right, that's an excellent question. And that's one of our advantages in our clinical studies, is the way we manufacture the device. The active and placebo are manufactured the same way, but we've removed and modified the circuit inside so that the power level does not reach the antenna. So it looks the same. You turn the device on, the light comes on, everything's the same, but they are electromagnetically tested. So we test to see if one has a signal and one doesn't. So. Yes, ma'am.
I know that you're targeting central sensitization by increasing the afferent noise. So when you have peripheral sensitization through local inflammation, those afferent nerves are quite sensitized from the inflammation. Is that when you would not use ActiPatch? Could that actually lower the threshold of these afferent
I understand the question. It's a great question. It's something I've been dabbling with for quite a bit. So what we find is if we look at the underlying mechanism, which is neuromodulation, no matter if it's ActiPatch or TENS or anything, we find that neuromodulation leads to activation of what we call the anti-inflammatory reflex that's been shown with the vagus nerve. And so there's some evidence indicating that neuromodulation reduces inflammation. So our understanding of it currently is that it increases afferent noise and reduces hypersensitivity, but we have some anecdotal cases that it does reduce inflammation, especially with chronic wounds and post-surgical pain. In fact, we had a researcher, independent researcher, publish a study on post-op C-section pain when we just got it a couple of months ago. And we still can't explain how or why it does that, but we've seen it does that. One more question, sir, and then we have to wrap it up probably.
Without any cultural disrespect, I just suddenly thought about the Chinese water torture trick, which is the continuous application of a non-noxious stimulus, a drip of water, on the forehead for a prolonged period of time, which leads to wind-up sensitization. We haven't heard anything that might happen with this.
That's a great question. In fact, believe it or not, somebody's asked me about the waterboarding and this water torture method. But if you think about it, that's where the difference is. With let's say, water droplets, that's deterministic stimulation. So there does have some temporal summation there and the chances of a wind-up. With the ActiPatch, the stimulus is about 1,000 times a second. So the activation of nerves is very non-deterministic in nature. And what we've found is that it takes a couple of hours before the nerves start to actually respond to it. So we have not seen any effects of wind-up so far, and I don't anticipate it because of the lack of deterministic stimulation. But to your point, if it was tense, yes, I would be concerned. But with ActiPatch, we have not seen it, or my understanding does not allow me to. So, does that help, sir? Okay, thank you. Well, I think with that, go ahead, Rawe. No, please. Well, thank you so much for your time and for asking me all those questions. I do enjoy, I did come to Australia, flew a long way. It's a great country, great city, and I hope to be back soon when you guys meet again. But thank you for having me. Appreciate it.